Well,
So, good evening, postgraduates, and my namaskar to all the new mentors, as well as the examiners, as well as the discussants who are there with us today. So, postgraduate, this is a All India Ophthalmic Society Academic and Research Committee's postgraduate program, and we call it a postgraduate program with difference because here we try to cover the uncovered aspects of other teaching programs which are available to you online from various sources. So today we will be having a journal club. The intent of starting the journal club was that journal club has become a dying entity in majority of the postgraduate teaching institutes in our country. There are about 350 odd postgraduate institutes which are in our country, out of which in hardly 25-30 places we have this journal club. So this is an effort to reinvent or rather rejuvenate this entity, and so that the postgraduates become familiar with this particular way of learning and way of reading the journals. So without much ado, can I request our member ARC South, Dr. Srinivas Joshi, who will be moderating today's session to carry forward the proceedings.
Thank you. Thank you, Prashant sir. Welcome everyone to the Journal Club. As Dr. Prashant sir, our chairman ARC, has spoken about it. So we started this postgraduate teaching program with the intention is to have long case discussions, short case discussions, chart reading, and the journal club. So every week we come out with a different niche topics and different subspecialty, so as to we try to train our postgraduate as much as possible, because there are certain things which are not available in the textbooks, and that will be brought out by the experts from the field of ophthalmology. So today we are having the journal club episode, that is episode number 106, and I must proudly say that it has been a very successful program. Lot of people watch on the ARC YouTube channel. If not, they have logged in today, but they log in later and see, and we have nearly 11,000 or 12,000 viewing rate sometimes in one of the most important articles. So, without much delay, I would like to welcome all our mentors today. Professor Dr. Vijay K. Sharma sir is a professor at Armed Forces Medical College, Pune. And so he'll be mentoring the presenter, Dr. Swati. And then we have another mentor, Dr. Annamalai, he's a glaucoma consultant at Arvind Eye Hospital, Puducherry. With this, we have a doyen of experts in the field of cornea and glaucoma. We have Dr. Virendra Sangwan, sir, who is the Director Translational Research, Dr. Shroff Charity Hospital, New Delhi. And then we have Dr. Deven Tuli, he's a glaucoma consultant at Narang Eye Institute, Delhi. And then we have our past AIOS president, Dr. BK Nayak, sir, senior head and consultant ophthalmology at PD Hinduja Hospital, Mumbai. So after presentation by these postgraduates of around 10 minutes, then it will be discussed by first by the mentor. What's the relevance of that journal in today's era? And what do we take the clinical impression from that journal, what we are discussing today? And then after that, our expert panel, Dr. Virendra sir, Dr. Deven Tuli sir, and Dr. BK Nayak sir will be exploring more about what is present in today's field and what is practical and what's the real world scenario, how we are going to stand with these new articles. So without wasting much time, let me introduce Dr. Swati Modi, the second year resident at Armed Forces Medical College, Pune. So she'll be speaking on the long-term corneal rejuvenation after transplantation of cultured human corneal endothelial cells. Over to Dr. Swati, please.
Good evening, sir. Myself, Dr. Swati Modi, under guidance of Colonel Vijay Kumar Sharma, will be presenting the journal club on the long-term corneal rejuvenation after the transplantation of the cultured human corneal endothelial cells. This article was published in American Academy of Ophthalmology in the year 2025. As we know, corneal endothelial failure is a cruel thief of vision. Whether it arises from the slow march of the Fuchs dystrophy, the unintended consequences of the surgery, or the collateral damage of the laser iridotomy, the result is the same, that is, a waterlogged cornea losing its transparency and with it the gift of clear sight. For years, DSEC and DMEC remain valuable but a limited option due to the global donor shortage, variable graft quality, inconsistent long-term outcomes. Cultured human corneal endothelial cell transplantation, when combined with the ROCK inhibitors, which acts as a fertilizer as well as a glue, represents a novel therapeutic strategy. This approach enables the use of the young donor cells and has the potential to treat hundreds of patients from a single donor cornea, addressing both the quality and the quantity constraints of the current practice. As we see in this image, the young donor is used where the endothelial cells are enzymatically isolated from the donor cornea's descemet membrane and are expanded in vitro to achieve the therapeutic cell dose. In the recipient cornea, 1.6 mm corneal limber incision is created and the diseased descemet membrane is removed. The suspension of the cultured corneal endothelial cells is supplemented with the ROCK inhibitor, which is injected in the anterior chamber, and the patient is asked to maintain a prone position for 3 hours. This will facilitate the transplanted cells to fix on the posterior corneal surface, forming an established functional endothelial monolayer. As we see in this video, there is a transplantation of the cultured human corneal endothelial cell is given. Under local anesthesia, we will mark the cornea. After marking the cornea, the epithelium is debrided. Post debriding the corneal epithelium, we will make a 1.6 mm incision. Post incision, descemetorrhexis is done, keeping the intact descemet membrane. After then, we will use Striffen glue to stain. Post staining, the incision site will be sutured with the help of 10-0 nylon and paracentesis will be done with 30 gauge needle. After that, 300 microliter of the cultured human corneal endothelial cells is injected and the patient is advised to maintain a 3 hours of prone position. Coming to the study, the aim of the study is to evaluate the long-term efficacy of the and the safety of the human cultured corneal endothelial cell transplantation. It is a prospective observational study where 65 patients were included and they were injected with the cultured allogenic corneal endothelial cells with a ROCK inhibitor into the anterior chamber. The patients were followed up for 24 weeks, 5 years and 10 years post-operatively. In methods, the patient eligible for the corneal endothelial cell transplantations are the corneal endothelial cell density with less than 500 cells per millimeter square or complete absence of the corneal endothelial cells. The corneal thickness of more than 630 micrometer were taken, where exception being one patient where the density of less than 630 micrometer were taken. The best corrected visual acuity of 20/40 were taken and the age group of 20 to 90 years. The corneal endothelial cell culture taken from the donor corneas of 7 to 29 years of age from the site life where they were stored at 4 degrees for less than 14 days. It was cultured at Kyoto Prefectural University, meeting the good manufacturing practices. The cell culture and the cell batches passing the quality control with an E ratio of above 90%, low CD44 expression, and PDGF BB secretion of above 100 picograms per milliliter were used for transplantation. At 24 weeks and at 1 to 10 years after the surgery, the corneal transparency, corneal endothelial cell density, and central corneal thickness were noted. In the exclusion criteria, the patients with an active corneal infection, any pregnant individual who has just given birth or are nursing mothers, patients with hemorrhagic diseases, individuals with mental retardation or mental disorder, or the ones who are incapable of understanding the procedure, glaucoma patients with poor intraocular pressure control, diabetic patients with poor blood sugar control, patients who were already hypersensitive to steroids, with systemic autoimmune disease, with any severe visual disorder, the one who has already received this therapy, the patient who has used or planning to use any anti-cancer drug, and the one with the heart disease or the cerebrovascular disease were excluded from this study. This study was carried out from December 2013 to January 2019, where 65 eyes were selected, out of which 38 eyes were from the initial clinical study and 27 eyes from the phase 2 and phase 3 clinical trials. The mean age in this study was 70 years. which ranges from 41 to 88 years, where mostly elderly individuals were taken, in which 30 male and 35 females were included, with a varied diagnosis of endothelial dystrophy and with the baseline corneal thickness of 762 micrometer. There were 20 donor-derived cell lots were utilized, all demonstrating the stable endothelial morphology without any evidence of epithelial mesenchymal transition. The baseline corneal endothelial density ranged from 1835 to 3140 cells, and the quality control was confirmed with the CD44 count and platelet-derived growth factor BB secretion of more than 100 picogram per milliliter at the final culture stage. If we see the outcomes after the transplantation, the outcomes were highly favorable. At 24 weeks, the overall graft success, which was defined as a restoration of the corneal transparency, and it was achieved to be 98.5% at the end of 24 weeks and 93% success rate at the end of 5 years. In terms of endothelial corneal density and endothelial cell density, nearly all eyes exceeded the critical threshold, where it was 500 cells per square millimeter, 98.5% at 24 weeks and 91.8% at 5 years. A higher density above 1000 cells per square millimeter was achieved in 93.8% at 24 weeks and 79.6% at 5 years. This indicates the durable cell survival. Central corneal thickness improved significantly with the normalization below 630 microns in 83.1% at 24 weeks and 85.4% at 5 years, reflecting a resolution of the corneal edema, and it remains stable at the end of 10 years. Finally, the visual outcomes were also very encouraging, where the individual has a gain of 2 or more lines of vision, and there is a 92.3% of eyes at 24 weeks and 85.7% at 5 years. Together, all these findings indicates the long-term efficacy in terms of transparency, endothelial function, corneal thickness, and visual acuity. If we see this image, before the cell transplantation, the central corneal thickness was 740 to 820 micrometer, which post-surgery decreased to 540 and 620 micrometer, and this remains stable throughout the post-op follow-up period. There was no serious adverse effects were noted. The individuals with the cystoid macular edema and the raised intraocular pressure were managed conservatively, while the incidence in this patient was similar to that observed after keratoplasty surgery. In Mary effect in methods, it is a prospective observational single-arm study where the intervention was given in form of cultured allogenic corneal endothelial cells with the ROCK inhibitor. The strength of this study is that it is a long-term follow-up study with the standardized preparation for all the individual. The limitations are there is a no control group, heterogeneous patients, and there is a 70% loss to follow-up. In assignment, there is a no randomization or blinding, and there is a variability of dose in all the individual, which is between 0.2 to 1 into 10 raised to the power 6 microliter of the cells. The assessment were the transparency, CEC density, CCT, and best corrected visual acuity was stable, and there is a no rejection noted. In results, the durable benefit in terms of restored transparency, normalized thickness, and improved vision were seen with the high safety profile, and better outcomes were noted when mature cells ratio of more than 90% were utilized in the study, which was done in phase 2 and phase 3 trials compared to the first clinical study trial. In interpretation, the safety, effectivity, and the durability of the study is good, with the limitation being only elderly cohorts were used with the variable doses. In extrapolation, it addresses the donor shortage where the one donor pair is utilized for almost 1,000 patients with the limited generalizability because only elderly individuals of the Japanese populations were used in this study. Coming to the conclusion, the cultured human corneal endothelial cell transplantation with the ROCK inhibitor is a safe and effective long-term treatment for the corneal endothelial failure with a high success rate in the corneal transparency, corneal endothelial cell density, and visual acuity improvement. There is no major complications or rejections observed, as well as tumorogenicity was also not observed. This therapy addresses the global shortage of the donor cornea. If we see the future directions, it can be used and the studies can be done in a form of randomized controlled trials versus conventional keratoplasty, use of pluripotent stem cells derived corneal endothelial cell transplantation, and optimization of the preservation and the transport methods. So to conclude, corneal endothelial cells can become a can helps in transforming the future of the corneal therapy. Thank you, sir.
Thank you. Thank you very much. Can I ask Dr. Vijay sir to please, Swati, can you please stop the screen share?
Right, sir.
Okay.
Yes, Vijay sir.
Yes. So Swati, very well presented. I think you covered. This was not an easy study to present with so much of data, but you streamlined it and presented very well.
Thank
Now,
you, sir.
most of times what we, yes, study design in this was it was a prospective observational study. So we usually get bias that study design has to be very good, and sometimes we neglect the other aspect. But despite just observational study, it got published in American Academy of Ophthalmology. So it has got some other very, very important strong points, not only in the methodology, but also as far as the translational research is concerned. Now, one, it is a potential solution to, I think, the global donor shortage. So that is one of the very important aspect that, as far as the translational aspect of this study is concerned, that is one. The second is a 10-year follow-up. Now, 10-year follow-up with this type of study, although they had different phase 1, phase 2, and phase 3 trials during the study, and they combine all the data of all these different trials into this prospective observational study. But 10 years follow-up is a very strong, that is again one of the strengths of this study, which it shows. The safety profile that the authors have come out in the study, no infection, no teratogenicity, and all those things. So again, safety profile as far as this study is concerned was good. Some of the limitations, in my opinion, was one, this was just single arm. There were no control groups, no comparison groups with the comparative or whatever is the standard treatment for endothelial failure at present in terms of DSEC or a DMEC. They could have done a randomized control trial, or maybe they might be doing, but they have not come out and published that aspect as of now. Then the other is in conflict of interest. They have explained their tie up with some pharma companies, biotech, and so that also is one of the important caution that we should have in mind if we find that generalizability of this study as far as the general population is concerned. The patient group that they had was only Japanese elderly patients, not included the children with the hereditary endothelial dystrophies or younger patients. So again, a particular ethnic group with a particular subset of inclusion criteria in this study. So that is also another. So this is as far as what I feel are the strengths and the limitations of this study.
Thank you, sir. Thank you so much. First, I'd like to open with Dr. Virendra Sangwan, sir. Sir, you have been a translational scientist and you have done a lot of work on these things. So I just wanted to know, as sir said, his first thing is about the donor tissue availability. The second thing is about the immunological concerns, especially when you have this HCEC transplantation. Now, the immunological response, I think, still remains as a concern, and it's not fully excluded yet. And what about the long-term graft survival of these cases and cell loss? Because shown that in the first 6 months, there will be some endothelial cell loss. So how does it going to survive for the long term? And also the technical challenges, like you have to deliver that HCECs along with the DMEC procedure to be done together. So how do we address these challenges, sir?
Thank you very much for the invitation, and thank you, Swati, very nicely presented. There are, and also Vijay, you outlined some of the strength and weaknesses of the study. But let me put in perspective. I have been following this work since 2010 when Professor Kinoshita first presented in Ventura, California, in a conference, and I have been very, very closely following and interacting with him. And a few months back, I was in Kyoto, and I had seen these patients with him. So, in terms of the quality of the data and everything, I think there shouldn't be any question. No conflict of interest, because in Japan, what happens is that these tech companies or the technology developed by the university is licensed to a startup or something like that. And that is what they have done here. The other aspect which does not come out in the journal is the cost. At the moment, it is very, very expensive. For each patient, it's about 60 lakh per eye per patient. And it is highly subsidized by the government at the moment, even though the company is a startup. So because they want to solve this problem and they are doing all this study, it is a big commitment. And Swati, for randomization, see, you don't need randomization if you're doing this observational case series kind of a study where you are trying a new intervention. Also, randomization will not be required when, say, for example, there is a DMAC or DSAC surgery works for endothelial disease, and there are historical controls and historical, you can look at the result for last 10 years, 20 years, 30 years. So you will find those things are you can compare. And when you're trying a new treatment, you really don't know the dose. So the dose will get sorted out in due course of time. You have to try different number of cells, pooled versus non-pooled. Endothelial, Srinivas, you asked about the rejection. See, that cannot be addressed by this issue until you work on HLA down regulation, or even though the HLA expression on the endothelial cells is not very high, but there are now new technologies where there are people working on silencing HLA, especially class 2 molecules and class 1 molecules. So this is a very, very interesting field. And scientifically, I think it's a very good advancement. Eventually, it will become a reality. But in biology and in human things, it takes a lot of time. Really takes 15, 20 years. Any other
Thank you, sir. Any other points from other expert panel? Dr. Vijay, you want to say something about?
Yeah, I just want to ask Sangwan sir. Sir, you have been very closely associated with Dr. Kinoshita, and I have heard your talks also about this. We are very lucky to have you on this panel for especially for this article. So, do they use any kind of immunosuppression as such? Because that was not mentioned as such in the article.
Nothing
No
orally.
immunosuppression.
Just like your DMAC.
Okay. So only the
Uh,
topical medications, no systemic immunosuppression as
No
such.
system is not really required.
Okay.
Sir, can I ask Sangwan sir? Good evening, sir. How are you?
Please go ahead.
Yeah. So, how do you think in the next 10 odd years, how do you think this will help us in the issue of cornea blindness?
I think the way I would think that the technology will evolve into, it would be like culture of the endothelial cells, which is pulled from different donors, and it is pooled like in a high quantity and ready-made available, and then you put it on some sort of a membrane, like a Descemet's membrane, a synthetic one, and then those cells are already adherent. So you will do like not a cell injection, maybe you'll do a DMAC, because the right now most of the cornea surgeons are very familiar with the DMAC and DSAC. So the transition probably will happen. It will evolve into a prepackaged, just like your eye or a contact lens that you will order from your eye bank or a cell bank, and it comes into, and you may be able to ask for, okay, I want the density of cells as 2500 or 3500, something that you can customize. So that would I would think that will come in the form of a preloaded injector, and this surgery will become eventually as simple, as straightforward as our cataract and IOL surgery.
So that's great, sir. I think that next 1 decade, something to really to look forward to, and I'm sure the cost will also come down for the Indian masses or for the world.
Yeah, that hopefully that would happen, but it'll probably take time because the technology development of this kind takes really a lot of time. So
That's
say
okay. I think
comment on the
something really to look forward to. Something really to look forward to.
yeah, yeah.
Great presentation, Swati, and great discussion by Vijay.
Thank you, sir.
Thank you, sir. Dr. Nayak sir want to say something, but I think he's
Dr.
on
Nayak,
mute.
you are muted.
Yes,
You can
Nayak sir,
mute
you're
yourself.
muted.
sir.
Sorry. Yes, yes.
Yeah.
So it's a very it's exciting development which is taking place in this field, and it looks very promising. There's no doubt about it. And the presentation also was fantastic. Swati did it very nicely. Just one suggestion to Swati that when she was showing the video, it's
Sir,
not that we did.
sir,
Basically, the research
Authors
protocol.
did.
This
sir,
was the procedure. Number one. Number two, that when she was describing the aim of the study or the procedure, it's
sir,
everything is methods, past tense now, because it has been done. It was this was the aim. This has been done. So those things, these are minor. This thing,
sir,
minor deficiency, but otherwise fantastic.
sir,
And one thing probably I have some miss. Of course, it's everything takes time in development, and especially this kind of technology which is developing. That the article, the data of phase 2 and phase 3 trials also were pooled. So those data, because it's a highly controlled environment, means phase 2 trial is a highly controlled environment. So that way means it's a means we have to see. The future will tell us whether it's going to be for masses or not.
Yeah, I mean, there is what Dr. Nayak is saying is very true that at this stage, to say that we can probably have it for a large number of patients across the globe is too premature. Primarily because the technology extrapolation or use in different populations in different disease indication has to be done, and then the cost. This is a major, like it's a scientific success, but commercial success or not, that will we come to know in due course of time.
Sir, does
Thank you, sir.
addition of ROCK inhibitor to the cultured endothelial cells, can that cause the bias in terms of if you're using a ROCK inhibitor as such and with the endothelial cells supplemented? So,
No, should not be. It's basically a cell cycle modulator. So
yes.
it should not really cause any kind of a bias or anything. See, it's like if you are growing the cells in
Hmm.
the medium outside, like we used to do cultivated limbal epithelial transplant, we
Yeah.
do in the culture dish in outside. Now we are growing the same thing on the surface of the eye, and the eye's natural environment provides everything else. So it won't really affect. Yes, if you are manipulating too much, then you don't know how the cells may behave. But here the manipulation is really minimal.
Okay. Thank you, sir. If no further questions, Dr. Vijay, sir, we'll move on to the next presentation.
Yeah. Thank you, sir.
Yeah. Okay. So thank you, Dr. Swati, and yeah, be watchful because senior professors like Dr. Nayak, no, he rightly pointed out.
sir,
That's why we have such senior examiners here today. Thank you, Nayak sir, for bringing out your valid points about how to present. That is equally important than knowing the subject as well. Most of the postgraduates fumble here, and this is where it gives a chance for the examiners to take you in a different court. So he is attending from US. Thank you, Nayak sir, for being a part of this program. So next we have another interesting article mentored by Dr. Annamalai and being presented by Dr. Hari Badari Anand. Is from a junior resident from Arvind Eye Hospital, Puducherry. So we'll be speaking on phacogoniotomy versus phacotrabeculectomy for advanced primary angle closure glaucoma with cataract. So over to Dr. Hari, please. Start
Thank you,
sharing
sir.
your screen.
Esteemed moderator, esteemed panelists, dear colleagues, a very good evening to you all. Today we'll be looking at the article titled Phacogoniotomy versus phacotrabeculectomy for advanced primary angle closure glaucoma with cataract, a randomized non-inferiority trial. So we also have a QR code linked to the presentation for the benefit of the viewers. This is a direct link to the original publication. Coming to the background of the study, primary angle closure glaucoma is a major clinical subtype of glaucoma, which accounts for nearly 50% of all glaucoma-related blindnesses worldwide. Trabeculectomy with phacoemulsification and an intraocular lens implantation is considered the standard surgical treatment for advanced PACG with cataracts as of now. But complication rates are higher and more cumbersome to manage in phacotrabeculectomy. Goniotomy is another option that we have, which is minimally invasive and excises the diseased trabecular meshwork through a incision in the clear cornea. It is effective, safe, fast, and also has lesser complications. The lacunae which exist in the present body of literature with respect to phacogoniotomy in PACG are that the sample sizes are small. We have shorter follow-up periods which do not match to real-world scenarios, and we do not have a study which has a comparison on pitting phacogoniotomy with phacotrabeculectomy. Now, coming to critical appraisal of any study, we follow the PICO framework, which stands for population which is being studied, the intervention that is being planned, the control group which we are comparing against, and the outcome measures for the same. Looking at the PICO for this article, we see that the population of interest is patients with advanced primary angle closure glaucoma along with cataracts. The intervention being planned is phacogoniotomy. The comparison group gets the standard care, which is phacotrabeculectomy, and the outcomes are the primary outcome, which was a reduction in the intraocular pressure from baseline to the 12-month postoperative period, and the secondary outcomes being cumulative surgical success rates, postoperative complications, and also the changes in the number of glaucoma medications which were needed. Now, the research question that the researchers had in mind is, what is the IOP change from baseline, the postoperative medication requirement, the success rates, and the complication rates of phacogoniotomy compared to phacotrabeculectomy in patients having advanced PACG with cataract over a 12-month follow-up period. Coming to the methodology of the study, it was a multi-center randomized control study, which was parallel assigned. Parallel assigned talks about a study design wherein, after splitting into two groups via randomization, each arm receives one set intervention, which it receives throughout the length of the study. This being a surgical intervention, there is only a single point of intervention, following which only follow-ups were maintained. It was an open-label study due to the difference in the surgical procedures and the methods employed for the same. So neither the patients nor the doctors concerned were masked with respect to what the intervention was for the patient, but the recruiters for the study and the statisticians measuring the data and analyzing the data were masked. It was designed as a non-inferiority trial with a random block size of 4, details which we'll go into further. Now, coming to the eligibility criteria for the study, the inclusion criteria were patients aged between 40 and 80 with advanced PACG and clinically obvious cataracts. Advanced PACG for the study was defined as 180 degrees of peripheral anterior synechia involving the nasal and inferior quadrants for surgical approach, an intraocular pressure greater than 21 millimeters of mercury with or without AGM control, a cup-disc ratio greater than 0.7, CDR asymmetry greater than 0.2, or superior or inferior rims lesser than 0.1 times the vertical disc diameter. Glaucomatous field defects on HFA with the CETA 24-2 or the 30-2 testing strategies with an MD worse than minus 12 decibel were also considered to be advanced PACG. Coming to the exclusion criteria, history of ocular surgeries other than laser peripheral iridotomy or laser iridoplasty or patients with trauma were excluded. Patients with other types of glaucoma, patients on warfarin and anticoagulation with an INR greater than 3.0, patients with retinal diseases that affected the collection of ocular parameters, monophthalmia, serious systemic illnesses, and pregnant and lactating patients were also excluded from the study. Coming to the sample size calculation, it was based on primary outcomes, and earlier studies have showed that the IOP reduction difference enabled through phacogoniotomy and phacotrabeculectomy at 12-month postoperative period were 4 millimeters of mercury. So we have taken, the study group has taken non-inferiority margin to be 4 millimeters of mercury at the 12-month post-op with a standard deviation of 6 millimeters of mercury for both the groups. For a 90% power consideration and a one-sided significance level of 2.5, we arrive at a sample size of 98 participants. And assuming a dropout rate of 20%, the investigators came to a conclusion of having 124 participants as a sample size for the study. Coming to methods for randomization, we are all familiar with simple randomization, wherein we have a group and a randomized and a computer program randomizes the group into either the intervention arm, group A, or the standard arm, which is group B. For example, it would be 49 and 51, or closer to 50 is 1:1 as the sample size increases. We also have another method called stratified randomization, wherein the initial group is split based on a set characteristic into two, as in with moderate IOP or high IOP in the purview of glaucoma. And then simple randomization is applied to both the groups so that we get an even distribution. Now, the study in interest has implemented block randomization protocols, wherein the patient group is divided into multiple blocks, here blocks of 4. Each block will have a 1:1 ratio of patients assigned to either the intervention arm or the control arm. And when we look at the same, there are only 6 combinations which are possible, which is listed on the screen. The computer chooses between one of the combinations for the hospital concerned, and the patients are allotted in a sequential manner. The advantage with the block randomization is that if the study were to be terminated earlier due to a superiority or a non-inferiority being very evident during interim analysis, the patient split that we already haven't had would be much more statistically significant, as in the randomization would be statistically significant and the results elicited from the same would be of more statistical value. They also reduce selection bias by randomizing the block size, and the investigator can be masked to the size of each block, which increases the complexity of the study but reduces bias by a further measure. Now, coming to the intervention arm, which was phacogoniotomy, the goniotomy would be performed either in the nasal or the inferior quadrant according to the surgeon's choice. The further details are very clearly described in the article along with a video supplementary. Goniosyneciolysis would be performed after the same by gently pressing down on all the peripheral anterior synechiae with a chopper. And then a Tanito microhook would be inserted into the anterior chamber through the main incision. And the tip would be inserted into the Schlemm's canal and incise the inner wall and the trabecular meshwork within a 120-degree range. Coming to the control group, which was phacotrabeculectomy, all patients in the control group underwent a standard procedure. A fornix-based conjunctival flap was raised. A rectangular 4x3 millimeter size superficial scleral flap of half to 2/3 scleral thickness was raised. Mitomycin salts sponges were used for 1 to 5 minutes, and the phaco was performed through a 1.8 to 3.2 millimeter clear corneal incision. Now, coming to the protocol that the study had in mind for postoperative IOP spikes. For IOP less than 18 millimeters of mercury, postoperatively, they would continue on to follow-up. For greater than 18 millimeters of mercury, they would first start on non-prostaglandin analog medications, following which a repeat measurement would be taken. In case of no further control, they would step up to prostaglandin analogs, and finally, they would go in for repeat surgery. So the hypothesis that the investigators had in mind was phacogoniotomy is non-inferior to phacotrabeculectomy in reducing IOP over a 12-month postoperative period, as mentioned in the study population of advanced PACG plus cataracts. So coming to more detail about what the study design that has been chosen for the study is, it is a non-inferiority trial. Now we'll go through a certain example to understand what a non-inferiority trial is. Here we have the mean drop in IOP shown on the x-axis, and in the y-axis we have plotted 2 interventions. Intervention A, which is the standard, and intervention B, which is the newcomer, which is the one that we're trying to compare against intervention A. Now, for the sake of this example, let's say that intervention A, the standard, reduced IOP by 15 millimeters of mercury, and the intervention B reduced it by 13 millimeters of mercury. The difference between the two D would be 2 millimeters of mercury. But this alone does not tell us whether the new intervention is non-inferior or superior to the standard intervention, which is A. For the matters of the same, we have to take into consideration a separate variable, which is called the non-inferiority margin, which will be derived from earlier studies of a similar nature. And phacogoniotomy or the new intervention can be established to be non-inferior to the standard only if the upper limit of the 95% confidence interval was seen to be lesser than or equal to the non-inferiority limit. We'll be going in detail about the same with respect to the results when we get there. For example, if we were to consider a drug A and a drug B, with drug A being the newcomer and drug B being the standard, let's say that it is something that we give for vitamin D deficiency. I've just taken that example for the sake of consideration. So vitamin A raised our vitamin D levels, the drug A raised our vitamin D levels by 70, and drug B raised our vitamin D levels by 100, which is the gold standard. And the non-inferiority margin with other studies was taken as 25 international units. Now, the null hypothesis would be that the new treatment A is inferior by an amount greater than the non-inferiority margin, which means that the difference in vitamin D levels caused by A with respect to B should be lesser than or equal to the non-inferiority margin. The alternate hypothesis would be the new treatment is non-inferior, wherein the difference caused should be more than the non-inferiority margin. Now, when we calculate the difference caused by the drug with respect to the standard would be 70 minus 100, which is 30. And this minus 30 is less than or equal to minus 25, which is the delta or the non-inferiority margin that we've already talked about, which shows that the new treatment is inferior. So this is how a non-inferiority trial would be working. But in this set case of an example that we've taken, it's showing that the new intervention is inferior. Now coming to the outcome measures for the study, the primary outcome was IOP reduction from baseline to the 12th month of follow-up, and the baseline was considered to be the highest IOP with or without AGMs measured preoperative. The secondary outcomes considered were cumulative success rates, postoperative complications, and also the change in the number of anti-glaucoma medications which were being used. Other outcomes which were looked at were visual acuity, degree of peripheral anterior synechia, the endothelial cell count, visual fields of the patient, surgical cost and duration, and also post-op quality of life of the patient. Success for the study was defined to be complete success when the IOP postoperatively fell between 5 and 18 and had a 20% reduction from baseline without assistance of topical AGMs. Would be considered qualified success when the same criteria were met with help of topical AGMs. The study would be considered a fail. And the patient's intervention would be considered a failure if the IOP were greater than 18 millimeters of mercury, or there would be a lesser than 20% reduction in 2 consecutive follow-ups greater than the third postoperative month period. Reoperation and also loss of light perception vision would be labeled as failure of the intervention. Now, looking at how the study progressed, 133 patients were assessed for eligibility and 124 were recruited and randomized. 65 went to the intervention arm of phacogoniotomy and 59 went to the control arm of phacotrabeculectomy, with 62 and 57 completing the planned 12-month follow-up respectively. I'd like to draw your attention to 2 terms over here. One is the intention to treat analysis, and the second is the number of patients who completed the follow-up. This brings us to 2 more statistical terms, which is ITT, that is intention to treat, and PP, which is per protocol. Intention to treat includes all the patients who are recruited into the study and have received the intervention, in our case being the surgical intervention at the point of care, and who have either completed or not completed the study. Per protocol analysis refers and includes patients who have completed the set protocol of the study to the exact term. So they would include patients who completed the 12 months of follow-up and have not gone in for any other deviations from the study. Coming to the results proper, in table 1, which analyzes the baseline characteristics, we see that the baseline demographics and the ocular characteristics are all having a p-value of greater than 0.05, which means that there is no statistically significant difference between the baseline demographic characters or the ocular characters, which is a result of the randomization that we've employed for the study. Coming to table 2, which looked at the primary outcomes, first, we look at the ITT analysis, which looked at all the patients who were recruited into the study. We see that IOP change at month 12 for phacogoniotomy was minus 26.1 millimeters of mercury. For phacotrabeculectomy was minus 25.7 millimeters of mercury, with a group difference being minus 0.4, which means that phacogoniotomy performed better in reducing IOP than phacotrabeculectomy in purely arithmetic numbers, but there is no statistical significance to the same. Looking at surgical success rates too, we see that there is no statistically significant difference in the success rates, whether it be qualified or complete success between the 2 arms. Coming to PP analysis or per protocol analysis of the same, we see a similar result with phacogoniotomy performing moderately better than phacotrabeculectomy in absolute numbers, but being of no statistical significance and having similar surgical success rates. Now, looking at the same table in a graphical representation, we see that this is the track of how the mean IOP fall has changed over the 12 months of follow, with no significant difference as elicited from the previous table. Now, coming to the most important figure of the study, which is this figure which talks about mean difference in change of IOP at month 12 after surgery. I like to draw your attention to the blue dotted line, which is at 0. So when the data point falls on this line, it means that the intervention offers no added benefit or change from the drop in IOP in comparison to the standard. The phacotrap reduced by 10, the intervention is also reducing by 10. The phacotrap reduced by 12, the intervention also reduces by 12. Right now, we see that in here, the mean is following towards the left of the 0 map, which means that phacogoniotomy reduced pressures more than phacotrabeculectomy. But again, the marks on the side, which are the 95% confidence intervals, do not come anywhere close to the non-inferiority margin. the non-inferiority margin of 4 millimeters with respect to the phacotrabeculectomy, which is the standard, has been marked on the right side of the graph in an orange dotted line. Now, looking at the ITT analysis, we see that the intervention is non-inferior to the standard surgical treatment that we offer for PACG with cataracts. Also, the investigators have gone ahead and have performed the same in another model, which is model 2, seen in the orange color, wherein they've included different covariates for a regression analysis, but they found that, again, the results were not changing from the earlier version, which is that the intervention arm is still non-inferior to the control arm. The same was also obtained through the PP analysis. Now, coming to the cumulative probability of success, which is shown here by this Kaplan-Meier curve.
Hari, can you please wind up?
Yes, sir. I'll get it. So we see that the complete success was 90.2 for the phacotrabeculectomy arm and 93.8 for the phacogoniotomy arm. And postoperative complications and interventions were seen to be higher in the phacotrabeculectomy arm rather than the phacogoniotomy arm, with the complications in phacogoniotomy being mostly hyphema and IOP spikes, and phacotrabeculectomy being AC reaction and corneal edema. There was also, I'd like to draw your attention to how the change in peripheral anterior synechia from the baseline has been seen across the groups, with 4.3 cloca reduction in the phacogoniotomy group and 1.9 cloca reduction in the phacotrabeculectomy group, which is of importance. Also, the baseline scores and the post-op scores for quality of life were measured for the control and intervention arms, which seem to be better in the phacogoniotomy. So coming to the discussion, phacogoniotomy is non-inferior to phacotrab, with a shorter surgical time, lesser complication rates, fewer interventions post-operatively, and a better post-op quality of life, with similar success rates and similar post-op medications compared to phacotrabeculectomy. Also, we have details on the number of failures and the number of reoperations that were needed, which had no statistically significant difference between the two arms. The strengths of the study were that it employed an RCT design, was a multi-center trial, and had low loss to follow-up rates, with the limitations being that despite being a multi-center trial, it was a single ethnicity study conducted in China. It was open label with no masking, and it only had a 12-month follow-up, which is short with respect to real-life symptoms. The conclusion being that phacogoniotomy is non-inferior to phacotrab for advanced PACG and cataracts, and can be considered as a first line in the select population, wherein complication rates are lesser and the quality of life is better. Thank you.
Thank you, Dr. Hari. It looks like you're the part of the study and such a detailed discussion. Congratulations for going so deep into that study. Annamalai, sir?
Thank you, sir. Thank you, Dr. Hari. It was a beautiful explanation of about the methodology of the study, which is very important for us, which is ignored. This study was mainly highlighted to highlight two important points. Firstly, regarding the clinical characteristics. Clinically, what we feel is in a very advanced glaucoma, phacotrabeculectomy is usually preferred. But this study employed patients with advanced primary angle closure glaucoma and suggested that phacogoniotomy is equivalent to phacotrabeculectomy, or rather non-inferior to phacotrabeculectomy. So now phacogoniotomy can be done as a first line of therapy even in patients with advanced PACG, also implying goniosyneculasis. So that's one thing. The second thing that we presented this article was to highlight about the methodology. So this is a randomized control trial. So we need to know what are the different types of randomization, which Dr. Hari has clearly explained. The most common ones are the simple randomization, the stratified one, and the block randomization. And they have employed the block randomization. And there are also disadvantages of the block randomization, because it is possible that if the investigator knows what the first two patients in the block underwent, he can predict what will happen for the next two patients. So these are inherent disadvantages when we employ a block randomization. And secondly, the most important one is to understand what a non-inferiority trial is. Again, a beautiful explanation was given. So we need to understand the concept of this non-inferiority margin. Just the mean being different between the two groups is insufficient to tell one is inferior to the other. It is that the mean with the 95% confidence interval should be less than the non-inferiority margin. So that's what we need to understand. And lastly, Yeah, I think these are the salient features that we need to understand from this particular study. Oh, it's open for discussion if others want to have some questions.
Uh, thank you, Annamalai sir. Thank you, Hari, for that wonderful discussion on the paper. I request Nayak sir and Dr. Deven Tuli sir to please open up. So, though I'm a vitreoretinal surgeon and we keep sending a lot of cases to glaucoma, we are the feeders to glaucoma, but not in PSCG, but definitely with the silicone oil or with the gas. So, sir, just wanted to ask the recurrences with this procedure, especially when you do phacogoniotomy, the peripheral anterior synechiae, the recurrences probably are more common, and in India, so where the patient non-compliant with the drops, that's why we go ahead with more of these surgical procedures, and suddenly if it recurs and following up these patients also is a challenge. So. So how do we differentiate and what are the merits and demerits of these procedures? Naik sir and Deven sir. Naik sir, you're muted.
Again, yeah, okay. So the first thing that I want to compliment Hari, that it's a very nicely presented, and it also showed the depth of knowledge and research. So I mean, just at one point in time, I was thinking that probably I'm conducting a research methodology workshop, and where he's giving a lecture. So it's a really, it's a fantastic. And the second part, that just one or two minor thing, that whenever I always emphasize that whenever you are telling the two data from the two groups, then basically research conclusion is based only on the statistical analysis. So whether either it is significant or non-significant. So don't just try to say that this was little better but statistically insignificant, because then simply say that this is statistically insignificant, because otherwise the reader or the listener will get confused, that they will start thinking, oh, this is showing more, means more drop in IOP, that's why this is better. But then the second line you are telling it's insignificant difference. So which one to consider? Whether there is a difference or no difference. So that means one should try not to over means, what I say, that sometimes in enthusiastically you say that, oh, this is showing better result. So the conclusion should be only on the whatever is the statistical outcome is. The other thing that in your description, probably you should have described limitations and strength, but I understand that because you spent so much time in explaining the methodology, that's why probably you missed out that. But that part should be at least mentioned, that what are the strength and weaknesses of this study. So that way, it's a very good study and probably good example of a good methodological procedure which has been followed, and probably in analysis which the authors have written, that the if there was some dropout, because they had also mentioned how they have tackled the dropouts. So in the phacotrabeculectomy, they considered the for dropouts, because you don't know what was the outcome in dropouts. So they considered the best scenario in the dropouts in phacotrabeculectomy and the worst scenario in phacogoniotomy. So that was a very good plus point in this study, because it is showing that they were not biased towards proving the point that phacogoniotomy is not inferior or superior, something like that. So these things are there, but the follow-up period of 1 year is definitely a short follow-up period. So we don't know what is going to happen after some time, because as Dr. Srinivas just now pointed out, that sometimes they need resurgery. Because in 1 year period, the resurgery in this study was lesser in phacogoniotomy. But in long term, we don't know, because whenever we are cutting something inside the eye, we don't know what will be the reaction of the tissue inside the eye, fibrotic reaction and other reactions. So whether 5 years down the line, 10 years down the line, in what way it's going to react, we don't know. So it's a very nicely and very strong study, because I will say that it's a very strong study, and it gives a conclusive evidence that both are equal. So if one can perform goniotomy also, then they can try phacogoniotomy as well as whatever is their preference. So it's a, according to me, it's a very good study that nicely presented. And Dr. Anna Malai also chose a very good paper for this presentation.
Thank you, sir.
Thank you, sir.
Sorry.
Srinivas, you are
Thank you.
muted.
Thank you, Nayak sir. Thank you. Thank you for your words of wisdom. Devin Saab, muted, muted.
So I was just saying that one of the thoughts which we have is that any of these MIGS procedures, goniotomy including, may not lower the pressure enough to meet the target pressures for advanced glaucoma. So I think this is something which is good in this study because all the inclusion is advanced glaucoma. So it will bust that myth a bit. The second thing, the question to both the presenter and the discussant, so Hari and Annamalai, uh, how much is this blade available now, the Trinito? I know it's being done by Devinder, but are you also doing in Pondi now?
Yes, sir. We have 5 hooks available, and those are autoclavable.
So that's the thing. So how do you think this will extrapolate? Because the availability of that particular blade is limited. You have Arvind Group has availability through donors and demo blades. But how do you think we can extrapolate this data, say, for KDB? Because that is probably the more often used procedure for goniotomy.
Yes, sir. There is a difference between the Tanito and the KDB. The Tanito just makes an incision. It does not remove part of the trabecular meshwork, whereas a KDB has the double blade and part of the trabecular meshwork gets excised.
Got it. But how do you think the results will be if you could extrapolate?
If clinically, there have been studies saying Tanito is equivalent to KDB, but theoretically, when we look at KDB should be better than a Tanito.
So I think that's another thing which if you look at my first comment where the myth is that, MIG's procedures may not lower to target pressure enough, and most of the surgeries we do in India are for advanced glaucoma. So I think this will be good because are you having some experience of doing this in advanced glaucoma and PSCG at Arvind Pondi?
Yes, sir.
KDB?
Nowadays, most of
No,
the
no, no, not
surgeries
not
have
not
become,
Sunito. I was asking for KDB, goniotomy, and the results.
yeah.
Similar case scenarios or similar inclusion criteria. Do you think the results are equivalent for the small series that you may have?
Yes, sir, definitely. The number of trabeculectomies have grossly reduced nowadays. So most of the initial treatment of choice have become phacogoniotomies, either the Tanito or the KDB, usually depending on what the patient can afford. And if at all it doesn't work, we can as well do a trabeculectomy at a later date because the
No,
conjunctiva.
that's okay. What you're saying is all, theoretical. I'm saying in your own personal experience at Arvind Pondi, how's the result? Because
We are.
What Srinivas asked is also very pertinent.
So 1 to 2 years
So
follow-up, we have not started medicines in a lot of patients, just probably a very minuscule number.
answer my question was the target pressure. Have you been able to meet the target pressure in most of the patients you've done it?
Yeah, yes, sir.
So that's good. And the qualified success, of course, will be better if you can add medicines.
Yeah, definitely.
And I'm sure if the third comment is if you can do this for open angle glaucoma, POAG scenario, advanced POAG, would you think the results would be even better?
We need to do a study to assess, but we have been doing it for both all types of glaucomas, and we do see similar results. The patients are not requiring AGM, and they reach the target pressures.
Yeah, so I think PSCG, we know with our own experience that it tends to be more aggressive and more difficult to manage. My bet is that if you can have a little review of literature outside this for advanced POAG, I'm sure the results will be better. So I think it's a good lead, and hopefully more centers in India, Arvind Group, LVP, Shankar Nitale, individual practitioners who are listening will do this more often and don't have that myth that, MIGS will lower to 15 to 16 at the most and may not meet the target pressure for advanced glaucoma. So it's a good lead and very well presented by Hari and Annamalai, and a good choice. And great, great ARC symposium by Srinivas and Dr. Prashant.
Thank you. Thank you, Tuli sir. I just had a quick question to Tuli sir and Dr. Nayak. When Hari explained about the ethnicity differences, because it's done mainly in the Han Chinese patients, and we know that PSEG has some differences in the ethnicity, especially the shorter axial length in these cases of Chinese patients, and also the shallow anterior chambers. Probably that could be. But coming to the Indian scenario, does it have any implications when you say about these ethnicity? Because I was just reading one of the paper, and the surgical complication rates are almost similar between the Indian papers and the Chinese papers. So is there any real ethnicity differences among these two procedures when compared to India versus China
I'll just
patients?
add I'll just add one comment and then Dr. Naik can take over. I think two things. One, that PACG in certain parts of India is even higher than 50%, so it's more than half, and probably similar to what the Chinese would be having. And the second comment is, I am a firm believer that Indian surgeons are far better than Chinese. That's it.
No, that's a very encouraging comment, Dr. Devin. And but then definitely, so far as ethnicity is concerned, we were probably lying in between because it's our narrow angles are not as high as incidence of narrow angles as high as the Chinese population or Japanese population, but definitely much more than the Western population. But we are very close to Chinese and Japanese. So outcome wise, I don't see there should be any difference. And as Dr. Devan said that the Indian surgeons are far better than the other surgeons. Yes, if that we consider that, then we are in a better position.
Thank you, sir. Thank you very
But
much.
but in
Any
this
other?
study, in this study, one thing more, because it's not that because cataract was there, so removal of cataract itself also adds to the intraocular pressure lowering. And but since it was a randomized study and it's a well controlled and trial, so that way probably that factor has not should not alter the result outcome.
My thought is that, and Annamalai and Hari can contribute to this. Uh, I don't think it's possible to do any MIGS procedure without phaco, or in a phakic patient rather, especially if it's angle closure and Sinecate. Can you comment?
Yes, sir, we agree. Usually, if it's an angle closure patient, the first step would be to remove the lens. We don't have to
No,
do
I mean,
anything.
in terms of going in with any blade, it's very difficult with a phakic and shallow AC of ACG. So I think phaco was essential, and also don't forget that GSL must have contributed a bit too. So that is a confounding factor. There should be a third group here where GSL was not done. But it's good to do GSL. Just for the study, I think if without GSL there was a third group, then we would know how much is the actual incision of the angle making a difference. So I think it's a great paper for good leads to, like I said, great Indian surgeons we have and great Indian researchers. And hopefully we'll have more leads from this paper to have it in the Indian scenarios.
Thank you, Tulisa. In fact, me being a vitreoretinal surgeon, and I'm sure Dr. Bhavan Kule sir also. So, Naik sir, we were glued to both of the papers, to be very frank with you. Both the cornea and the glaucoma. So interesting papers and interesting discussions. So thank you, presenters. Thank you, mentors, and wonderful take-home pearls by our expert panelist. Which make other subspecialty people also get glued to these kind of discussions. So thank you very much, and over to Dr. Prashant sir, please.
You have thanked profusely. Let me thank profusely all the presenters as well as the mentors as well as the senior discussants for sparing their valuable evening with us for the sake of postgraduates. We are all indebted to you. So without much ado, it's time for us to say goodbye. Thank you one and all once more. Thank you.
You're
Good night.
sparing my morning, not evening.
Yes, sir.
Thank you.
I do
Thank you, sir.
acknowledge that. Yes. Early morning, that too. Breakfast time.
Good night and Shabak here to most of the Indians, and the Indian in America, Dr. Nayak, good day, sir. Have a good day.
Thank
Thanks,
you. Good
everyone,
night.
and good night to everyone. Bye.
Good night, everyone. Good night, everyone.